A freshman at a Halloween party was shot twice in the chest due to another intoxicated partygoer who didn't realize his toy gun was a real one. Bystanders assumed the excessive bleeding was part of the patient's costume, so the patient lost a significant amount of blood before responders arrived to the scene. The suspect fled the scene, law enforcement was contacted, and was able to successfully apprehend the suspect and get control of the weapon. MRU are dispatched to Sally Hall at approximately 12:36 p.m. in reference to a 20-year-old male possible gunshot wound.
Hello, 911.
911, what's your emergency?
I'm at Sally Hall. My friend was just shot.
Okay, the medical response unit is on the way.
Dispatch contacts the MRU, Rescue 1, and alerts them that there is a possible gunshot wound victim at Sally Hall.
Central Dispatch, this is Rescue 1 with a request.
Rescue 1, Central Dispatch, go ahead with your request.
Central Dispatch, Rescue 1, can you repeat the address for the call?
Rescue 1, Central Dispatch, you are responding to Sally Hall, 1498 West Call Street, Tallahassee, Florida. Do you copy?
Central Dispatch, Rescue 1, confirming Sally Hall, 1498 West Call Street, Tallahassee, Florida, 32304.
Rescue 1, Central Dispatch, that's affirmative.
Responders put on gloves, eye protection, a mask, and gowns en route to the scene. Law enforcement confirms that the suspect has been apprehended, the weapon has been removed, and the scene is safe. Responders arrive on the scene. Crowd cleared out several minutes ago due to mass underage drinking.
Oh, now we gotta go?
No need for crowd control, but we put in a call for an ambulance, EMTs, paramedics, only one patient. Responders determine that there is no need for spinal precautions. A bystander waits by the front desk and runs over to the team as we arrive.
Can you tell me the patient's name and what happened here?
It's Brandon. He was shot by the guy dressed as a police officer.
That's not your gun. This is your gun.
It all happened so fast. At first we thought the blood was part of his costume, so we just left him there. He's bleeding out.
Bystander quickly leads us to the patient, who is in a supine position, clutching the right side of his chest with a bewildered look on his face. We have an approximately 20-year-old male who appears to be responsive but unaware of his surroundings. He is in a supine position and is continuously asking how he got there, appears to be in severe distress due to his injuries.
Hi, Brandon. My name is Claudia, and I'm with the FSU Medical Response Unit. Can I help you out here?
I get here. How'd I get here?
Don't worry, we're gonna help you out and make sure you get to a hospital, okay?
Brandon doesn't respond, is no longer alert.
Brandon, are you good? Can you hear me?
The responder administers a pinch to the shoulder and a sternum rub when he doesn't respond to verbal stimuli. Patient is determined to be unresponsive after having no reaction to painful stimuli. The responder quickly assesses the ABCs while getting the bleeding under control.
The patient is breathing and no unusual sounds can be heard at this point. The airway appears to be free of obstruction and the patient shows signs of delayed capillary refill time.
Responders perform a head tilt chin lift to ensure the airway is as patent as possible.
The patient's breathing is shallow, labored, and coming at a rate of 7 breaths per minute. The patient's skin is pale, cool, and moist, and the patient has a rapid, weak, carotid pulse.
The patient is then determined to be high priority because he is unresponsive. The responder palpates under the patient's back for an exit wound. None are found. Responders expose the wound by removing clothing and other material around and on the open wound. Responders apply direct pressure using clean dressings to manage bleeding. Then a commercial chest seal is applied once bleeding is relatively under control. Responder administers oxygen via a bag valve mask connected to an oxygen reservoir. The responder reassesses that the intervention was appropriate. The patient had problems with perfusion and breathing, So the responder made sure immediate life threats were corrected. The patient is no longer bleeding out and now has a breathing rate of 10 breaths per minute. So the interventions are adequate.
Responders perform a rapid secondary assessment after determining the patient has a significant mechanism of injury, which is 2 gunshot wounds to the right side of the chest. DCAP BTLS would be checked throughout the assessment for each of the steps. The responder begins by checking the head for bleeding and deformities, then examines the patient's eyes for signs of injury using Pearl. They then inspect the ears and nose for drainage, either clear or bloody. They then inspect the mouth for foreign material, bleeding, and tissue damage. Next, they check the neck, front and back for pain and deformity. They then use both hands to inspect the chest, front and sides, for pain and deformities, observing for equal expansion of both sides of the chest and any paradoxical movement. They then inspect the abdomen for any signs or symptoms of trauma such as pain, deformities, distension, rigidity, or guarding. Next, they inspect the pelvis for pain and deformity. They then feel the lower back for pain and deformity. Next, they check each leg and foot individually. They then check for distal circulation, sensation, and motor function. They use the dorsally pedipulse and then examine upper extremities from shoulders to the fingertips. Lastly, they check for distal circulation, sensation, and motor function in each hand. This rapid secondary assessment, head-to-toe secondary assessment, was performed in less than 90 seconds.
During the rapid assessment, we found that the mouth is clear, no blood or obstructions are seen, accessory muscle use is seen in the neck to assist respirations, there is unequal expansion of the chest during respirations, there are 2 penetrations due to gunshot wounds on the right side of the chest, and they do not appear to have exited the body. There is also bruising surrounding them and bleeding. Crepitus is not heard when palpating, and other aspects of the rapid assessment appear normal.
Responders attempt to take blood pressure via auscultation, but background music prevents an accurate reading, so blood pressure via palpation is performed instead.
Blood pressure is 105 by palpation and dropping. The patient's pulse is rapid, weak, and irregular in rhythm. The patient's pulse is also showing signs of compensated shock heading towards decompensated shock. The breathing rate was 7 breaths per minute prior to the use of the bag valve mask, and breaths are now shallow and weak and coming at a rate of 10 breaths per minute. Patient's pulse is 145 beats per minute, weak and regular. The patient's pupils are round and reactive to light, but slightly sluggish. The skin is pale, cool, and moist, appearing slightly cyanotic at the lips. Oxygen saturation is at 90% initially, but increases to 92% as the oxygen is delivered with the bag valve mask. A pulse oximeter is used to measure the oxygen saturation. Do you know if Brandon has any allergies?
He's allergic to, I don't know, he's allergic to dogs or something. I can't remember. Wait, he's allergic to penicillin? Penicillin? I don't know how to say it.
You mean penicillin? Anyway, do you know if Brandon has taken any medications today? It could be anything.
Oh, not that I know of. He was drinking, though.
Did Brandon have anything to eat before coming here tonight? Did you guys stop anywhere like Whataburger or other restaurants around town?
No, I'm not sure about the last time he ate. We only had drinks when we were here.
All right, just a couple more questions for you, Joey. You're doing great. How exactly did he end up getting shot?
It was this kid dressed as a cop. Somehow he didn't realize that his gun was real. He shot him twice before he figured it out.
Was the shot from a close range or from further away?
It was about 10 feet away. The guy was so shocked he had to shoot him twice to make sure that it really happened. It was crazy.
Thank you, Joey. That'll be all.
The responder rechecks vitals every 5 minutes until EMS arrives and transfer of care occurs.
The patient was a 20-year-old male gunshot wound victim who presented an altered mental status upon our arrival to the scene. According to a bystander, the patient was shot in the chest multiple times due to a costume malfunction and bled out for several minutes before our arrival. The patient remained still before going unresponsive, providing us with the implied consent to intervene. Our primary assessment revealed that he was disoriented and then suddenly unresponsive to verbal or painful stimuli. To be specific, my partner raised her voice to ask the patient repeatedly if he was okay, and when he did not respond, administered a pinch to the shoulder as well as a sternum rub, neither of which he responded to. The patient's airway was open with no visible obstruction, but his breathing was shallow, labored, and coming at a rate of 7 breaths per minute prior to oxygen. Circulation was present but inefficient, as shown by his pulse, which was rapid and weak, and his skin, which was pale, cool, and moist. The patient was bleeding profusely from 2 gunshot wounds to his right pectoral, so we controlled the bleeding by first checking for exit wounds, and when none were found, applying direct pressure with clean dressings, adhering a chest seal, and administering oxygen via BVM connected to an oxygen reservoir. Our secondary assessment began with a rapid assessment using DCAT BTLS. A full head-to-toe examination revealed that the only mechanism of injury were the 2 gunshot wounds to the patient's right pectoral. Blood pressure was found at 105 by palpation rather than auscultation due to the difficulty of hearing through the party music that was still playing. The patient's pulse was rapid, weak, irregular in rhythm, and showing signs of compensated shock, coming at a rate of 145 beats per minute. The patient's respirations during the secondary assessment were shallow and coming at a rate of 10 breaths per minute, a slight increase from 7 breaths per minute after the BVM was introduced. Patient's pupils were round and reactive to light, but slightly sluggish. Oxygen saturation was 90%, but increased to 92% after oxygen administration via the BVM. A bystander confirmed that the patient was allergic to penicillin. The bystander did not know if the patient was on any medications, and his medical history and last oral intake were also unknown. Based on the information gathered during patient assessment, we concluded that due to the injuries inflicted, the patient was likely suffering from hypovolemic shock, more specifically hemorrhagic shock due to a significant loss of blood. We checked for an exit wound, and when none were found, we applied direct pressure with clean dressings, then adhered a chest seal. The method used to control the bleeding was efficient, and the hemorrhaging stopped at the pectoral muscle. The oxygen delivered via the BVM helped to increase breathing rate by about 3 breaths per minute and oxygen saturation by 2%. Responders continued to monitor the patient's ABCs and vitals until paramedics arrived. When a patient has a penetrating chest injury, specifically a gunshot wound, you must inspect the torso on all sides for exit wounds. If exit wounds are found, they must be equally cared for along with the entrance wounds. Open chest wounds should be managed the same way as any open wound would be, with direct pressure. But the use of a chest seal may also be helpful once the bleeding is relatively under control. Provide high flow oxygen and care for shock. Hypovolemic shock is characterized by significant fluid loss, falling blood pressure, and the overall failure of the body's circulatory system. The patient should be kept in supine position, any external bleeding should be controlled, oxygen should be administered, and the ABCs and vital signs should be continuously monitored. When the patient is responsive, it is also important to emphasize therapeutic communication to calm and reassure the patient.